Hello everyone, and today, as we used to, we'll study this book and read it. The first rib. The first rib is atypical, as you can see. It is flattened from above downwards and is shorter and more curved than any other rib. It shows prominent rough areas on its upper surface where the scalene muscles arising from the cervical vertebrae attach to it. The first rib is often grooved between the muscle attachments by the roots of the brachial plexus and the subclavian artery. A similar marking may be made by the subclavian vein in front of the attachment of scalenus anterior. Attachment for scalenus medius, groove left by brachial plexus and subclavian artery. Attachment for scalenus anterior, groove left by subclavian vein, scalenus medius, brachial plexus, subclavian artery, scalenus anterior, subclavian vein. The first rib and structures related to it. Costal joints. As illustrated, each rib has several articulations. The major articulation of the head of each rib with the vertebrae is seen best. The inferior facet of the head of each of rib 2 to 9 articulates with the superior demifacet on the body of the corresponding vertebrae. The superior facet articulates with the inferior demifacet of the vertebrae above and with the inner vertebral disc between them. The heads of the ribs 1, 10, usually 11, 12 have a rounded head with a single articular facet that articulates only with the corresponding vertebrae. These joints are all synovial. As seen, the tubercles of the first 10 ribs form synovial joints with the facet of the transverse process of the corresponding vertebrae. Strong costotransverse ligaments unite each rib and vertebrae. The double articulation of each rib with the bodies of 2 vertebrae and the transverse process of its corresponding vertebrae and the relative positivisms of these attachments means that the ribs twist on their articulations rather than slide up and down. The sternum. Identify the 3 parts of the sternum, the mandibular body, and the xiphoid process. We have already met this while studying the surface anteronomy of the thorax. These components develop separately but fuse by late teenage. The concave suprasternal notch is the upper border of the mandibular, deepened by the sternal ends of the clavicular articulating with the sternum at the synovial sternoclavicular joints. The costal cartilage of the first ribs articulate immediately below the sternoclavicular joints. The body articulates with the mandibular by a fibrocartilaginous joint, allowing movement of about 2 degrees during maximum inspiration. This joint produces the sternal angle. The second costal cartilage articulates with the sternum at this level. The third to seventh costal cartilage articulate with the body of the sternum. The xiphoid process extends downwards and slightly backwards from the body so that the interior surface of the xiphoid is thus inset. The xiphoid varies in length and is made of cartilage initially. In older age, the cartilage usually calcifies. Sternal notch, manubrium, synchodrosis with first rib. Body composed of 4 sternae, articulation of costal cartilage, xiphoid process, costal cartilage, the sternum and its articulation with ribs, thoracic muscles and intercostal spaces. The articulations of the costal cartilage with the sternum are also shown. Some connect directly whereas others are attached indirectly. The first 7 ribs articulate via their costal cartilage directly with the sternum and are known as true ribs. The cartilage of 8, 9, 10 articulate with the cartilage immediately above them, and hence the sternum by the 7th costal cartilage. These are false ribs. The 2 lower ribs are diagnosed as floating ribs because the short costal cartilage of ribs 11 and 12 are free. The cartilage of the true ribs originally articulate with the sternum at synovial joints, but the cavities of these synovial joints are usually obliterated by fibrous union. The first costal cartilage is united with the manubrium by a synchodrosis. Rib fractures are outlined. General features of the thoracic cage. There are several features of the thoracic cage that are important to understand in the context of movement of chest wall. You can confirm the points listed below on a mounted skeleton, and some of the features can also be seen. Most ribs run downwards and anteriorly, but their costal cartilage run upward and anteriorly. The first rib and its costal cartilage run downward throughout. The sternal attachment of each rib lies downward than its vertebral attachment. The middle of each rib, around the mid-clavicular line, lies lower than the other end. Ribs and their cartilage increase in length from the first to 8th rib, then decrease again. The transverse diameter of the thorax is thus maximum of 8 ribs. The inferior margin of the cage is formed by the 12th thoracic vertebrae posteriorly, the 12th rib, and the tips of the 11th ribs at the sides, and by the cartilage of the 12th to 7th ribs anteriorly. In the anterior midline, the margin is formed by the xiphoid process. Fractures of the ribs. The ribs are not fully ossified until adult life, so the rib cage of children is very flexible, fracture rare. In adults, rib fracture tend to occur near the angle. The upper 2 ribs protected by the clavicular and the lower 2 floating ribs are the least likely to be fractured. Thoracic muscles and intercostal spaces. The thorax cage is more or less entirely covered in muscles, mainly such as the pectoral muscles running from the anterior thoracic wall to the humerus in the upper limb, and the abdominal muscles running from the lower ribs down to the pelvis can play a role in ventilation. The intercostal muscles of the thoracic wall are located beneath the postural muscle layer. Intercostal muscles. The intercostal spaces between the ribs are occupied by intercostal muscles attaching to the ribs above and below each space. The muscles are arranged in three layers, but the practice only the two outer layers are functionally significant. The external intercostal muscles form the outer layer, and their fibers run forwards and downwards. Each muscle extends anteriorly from the tubercle of the rib as far from as the costal chondral junction, whereas replaced by a fibrous aponeurosis. The internal intercostal muscles make up the middle layer, and their fibers run backwards and downwards. These muscles extend from the sternum anteriorly to the angles of the rib, where they are replaced by aponeurotic tissue as shown. The fibers of the external and internal intercostal muscles run at right angles to each other. The intercostalis intimi muscles form the inner layer. This muscle layer is usually incomplete. Muscle is only present in the lower intercostal spaces and in the middle part of the ribs. Their fibers are oriented in the same direction as the internal intercostal muscles and function with them. The intercostal muscles play a major role in the ventilation. Both external and internal muscles elevate the ribs, but the internal intercostal can also depress the ribs, depending on the action of other fixator muscles. Intercostal neurovascular bundles. The main vascular and nervous supply to the tissues of intercostal space and adjacent tissues. Intercostal, the main vascular and nervous supply to the tissues of the intercostal space and adjacent tissues runs as a neurovascular bundle just below the costal groove of the rib, forming the upper boundary of each intercostal space. The nerves and blood vessels are protected by the sharp inferior margin of the rib. The bundle runs deep to the internal intercostal muscles. The intercostal arteries supply the skin of subcutaneous tissue over the side of the chest wall and give branches to the intercostal muscles and underlying the pleura. Perforating branches pierce the chest wall to supply the pectoral muscles and the breasts. In the lactating female, these vessels may be considerable size. Corresponding veins run with the arteries. The intercostal veins are the ventral primary rami of the upper 11th thoracic spinal nerves. Their course of distribution are illustrated. Trace them as you read the description. Each pair of spinal nerves emerges from the inner vertebral foramina, formed between two adjacent vertebrae on each side. The nerve immediately splits into two branches, the ventral and dorsal primary rami. The dorsal primary rami supply the muscles acting on vertebral column and skin immediately overlying the vertebra posteriorly. The ventral primary pass through Lili to form the intercostal nerves and the infracostal spaces running with the intercostal vessels. A lateral continuous branch emerging near the axillary line supplies anterior innervation to the skin over the side of the chest, and an anterior cutaneous branch near the edge of the sternum supplies the skin on the front of the chest. Next lecture we will study several motor branches. These are appreciated from its center, and we will see these pictures. Thank you for joining this lecture, and we will meet next time.